So this patient is a 30-year-old white female who has Medicaid Aetna. She was diagnosed with Hep C in 2022 and at our facility. She came in the day I saw her. She was new to me. She was referred to me. She came in with her mom, who was really supportive. Her biggest risk factor for Hep C was IV drug use that had started at age 25, but she has been in recovery for 4 months and feels very solid in her recovery on Suboxone. She's never used alcohol. She does have a non-professional tattoo, and she did have one sex partner with Hep C. I didn't get dates on those. She has had a BTL, 2 pregnancies and 2 children, 2 live children, the one of whom she lost after it was born. And she told me that that's actually what led to her substance use. She does have a history of congenital hip dysplasia and is followed by Dr. Tabbitt in Morgantown. She's had 22 surgeries, but she didn't talk about pain from that, so that was interesting. She's obese and has allergic rhinitis. She uses e-cigarettes. First, I wasn't sure what I read there, e-cigs, then I realized. Medications were fluticasone for her allergies. She's currently on Ozempic, trying to lose weight, Suboxone and Miralax. She's immune to Hep A, natural immunity, and I believe she was not immune to Hep B, and I believe we've started vaccinating her. That was our intention. I'll make sure that we've done that. On labs, her CBC was good. Liver enzymes were normal. You could keep scrolling down there. Her APRI, as you can see, was 0.28. She's child Turco-Q class A, and the MEL score was 8. Her iron studies were normal. Her vitamin D was in a good range. I didn't add supplementation for her. She's HIV negative, genotype 1A with a viral load of 196,000, and her serum fibrosis marker was F0 to F1. I don't think I have seen an ultrasound on her, although I have ordered it. At the time when I submitted, I didn't have the INR, so I didn't do the other calculations, but that I did send those in once I got the INR. And so I would treat her with either Epclusa or Mavorite. And I don't think there are any contraindications with her interactions with her medications. So I just would need any feedback on that or anything else that you all see.
Thank you so much, Jennifer. I think my internet is unstable, so if I disappear here for a second, you guys are experts, you know what to do. But
Okay.
yes, any clarifying questions or comments to Jennifer about this case in particular? All right, and any feedback, comments about this case? Dr. Gilfus, I see you unmuted there.
Hey, Jen.
Hey.
Hey, was this patient tested? I always like to know the why they tested. Was it requested, or was it because of the IVDU history, out of curiosity, or is it because of the Suboxone program?
I can't remember the story on that. I think it was because of the drug use history. Probably. I just don't remember.
No, that's fair. It's totally get it. Beautiful story, because this is right when you want to catch somebody early on and in a good spot. So you have that maximum 5 years of impact of this Hep C. And the other question, it said a sexual partner with Hep C. Do we know if that's ongoing or not? Guys, that would be the only other thing.
You know, I'm sure that's in my notes. I didn't include that and I'm sure I talked to her about that. So I can go back and look at that. I don't have her chart up in front of me, but I did talk to her about transmission and about I would have talked to her about testing for partners. So I'll double check on that.
Perfect. That's great. And then you got your Hep B poster or booster. You know, I don't even think you need that INR. I don't even think you need an ultrasound. I think you're rocking. She's you know, we had this really incorrect rule of thumb that I was taught years ago, which is not true. But we learned that, you know, after 5 years, expect one F score, and that's not true. But it's nonetheless, it fit nicely in this lady because we have 5 years of infection and maybe an F1. So I was like, oh wow, that's convenient. But obviously we know that rule of thumb is not accurate. But that's a great time to treat her. I think your MAV reader up boost is perfect. No contraindications identified from my end. You're rocking. Good job. What a good time to get her treated. Well,
yeah, I was really happy she came. And so that would mean if I don't need ultrasound now, then I don't need any surveillance in the future if she's
you're right on. You're right on. Yeah.
awesome. Okay, great.
No HCC stuff. No nothing. Should be a good cure. Put it behind her.
Beautiful. Thank you.
Thank you so much for that feedback, Dr. Gilfus. Any other comments from the group? Tammy, go ahead.
Yeah, I was wondering, Jennifer, it seems like you have a continuous influx of patients with Hep C. And I was wondering, are they just coming to the clinic, or do you get referrals or find them through the MAT program? Or
So some of them are through Matt, which you know I do, but I have to say credit to my colleagues. I have and I've had to tell them, hey, I'm treating this, and most of them are referred from my colleagues in-house, which means they're screening, and it's really gratifying to see people.
Yeah,
and I know they're happy to be able to refer in-house too. So.
Yeah, it's great to see you treating them. So
yeah,
many.
yeah, it's really I really like this part of my work right now, and it's just great to be getting the in-house referrals. It just feels like the whole team is working to help the community.
Yeah.
I want to make sure, Rachel, that Ozempic is okay with Maverick or Epclusa.
Yeah, the only there's no direct drug interaction with it. The only is she using it primarily for weight loss, or does she have like a pre-diabetes component?
No, it'd be for weight loss.
Okay, yeah, because the only thing with those is just remember that the direct acting antivirals basically kind of help or enhance that hypoglycemic effect. So that's just the only risk we have with our diabetic patients. And if she's just using it for weight loss, she could still monitor. I would just kind of, just in case, make sure she knows the signs and symptoms of low sugars. But there's no direct sort of interaction there where I'm concerned as far as Maverick, Epclusa. Both are fine.
Great, thank you. Okay, thanks, Mitra.
Of course, thank you. Any further questions, Jen, about this case?
No.
All right, perfect. Thank you all so much. Let me pull up your second case now. Okay, can you see that okay?
Yeah, so these two, the person I just presented and then this lady came to me within the same 2-week period, referred from a colleague, and they're both young women. This was a 34-year-old Caucasian female, Unicare Medicaid. And her diagnosis was during prenatal care. She delivered about 7 months ago. So it was 2022 that she was diagnosed. Interestingly, no one had talked to her about when to get her newborn, her child who was just born tested. So she and I had a conversation about that. But at any rate, her risk factor was IV and intranasal drug use in 2020. She had been sober since 2021. She had one relapse in April of 2022 that was smoking heroin, not IV or intranasal, and her sobriety has been solid since then. She has no tattoos and no known sexual contact. So it's just the drug use that led to her hep C infection. She had no physical symptoms related to infection. At the time, she didn't know her hep A or B status. I'm sure I have that listed somewhere when I get further down. She was her current contraceptive method was abstinence. But I talked to her about if she gets a new partner, using protection. For both hep C and other STDs and for pregnancy. She does have depression and anxiety, which are currently being treated, and she uses tobacco. She's on Celexa, and I always forget what that is. Quetiapine, is that Seroquel, I think. But anyway, Rachel can remind me. She came to me on vitamin D supplementation. We did test her, and she was immune to both hep A and B. Her BMI was a little bit low. She was a thin lady. Labs were fine. That's interesting. I don't see her CBC there. Is why I keep saying but I'm sure it was fine. And the other labs, ALT was slightly elevated, but other liver enzymes were normal. APRI, child-to-CoQ, and MELD were all in a good range. Iron studies, normal. Vitamin D was low when I saw her, but she was on supplementation. She's HIV negative. She's genotype 2 with a viral load of 174,000, and she was an F0. The day I saw her, her HCG was negative. Yeah, so that was Seroquel. And I wanted to make sure that there wasn't any interaction between that and Epclusa or Mavorite. And I did talk to her about contraception, as I mentioned. Maybe I was the one who started her on vitamin D replacement. Yeah, that's my only question that I can think of is the Seroquel. She's very similar to the previous case. I feel pretty excited that my colleague tested her and referred her to me, and that we can not only get her cured, but also monitor her baby.
Thank you so much, Jen. Another great case. Any questions or comments about this case? All right, and does anyone have any recommendations or feedback for Jennifer? Dr. Gilfus?
Hey, Rachel, do you want to hit the Mavorite Seroquel thing, or?
Yeah, I can start on it. So as far as the interaction with is primarily going to be with the Seroquel and the Mavorite. However, it's not something that I'm usually concerned with, especially because this looks like a pretty low dose, this 25 that's listed here. So I don't have any hesitation. The normal things that you would see with higher doses, really just because the Mavorite can increase the amount of the Seroquel. So Seroquel toxicity type things. QT prolongation, and that is being the major thing. But at that low dose, I don't have any hesitation with the Mavorite on there. The Epclusa doesn't have an interaction with any of these two, so that's also an option. But that doesn't sway me to, as far as the interaction goes, to use Epclusa over Mavorite, because it doesn't really seem clinically relevant at that dose.
Okay, so you don't think it would make her like more tired? She takes it for sleep, but wouldn't it make her more tired, or could it?
No, not at that, not with
Okay.
the amount of that, the impact of that interaction and that low dose. I really don't think it would impact her clinically at all.
Okay, thank you.
Yeah, and in terms of other stuff, yeah, either drug, because it's genotype 2, you're a bit limited, no Harvoni, no Zepitir. So you really have your choices of Epclusa or Mavorite, like Rachel was saying. And then, no HCC screening or anything necessary. What a cool case. This is almost like lifetime diagnosis. At most, she's had this for 2 years. Compliments to you and your group for doing that while she was, part of the prenatal screening. And not only will this be amazing personal benefit, imagine the such societal potential impact. I know she's sober now and hopefully it would stay that way, but even future mother-to-child transmission and everything else is going to be stopped, hopefully, with treating her early. So good stuff. Well done.
Agreed.
And no bad news on this one.
Okay, thanks. Yeah, agreed. Both of these two were really satisfying people to have come into my office. So thank you all very much.
Yes, thank you all so much, including you, Jennifer, for bringing these two cases today. Any other questions, Jen, about either cases? All
Good,
right,
thank you.
perfect. Thank you so much. Rachel, I see you unmuted.
Yeah, just to throw it in, because you mentioned it, as far as the contraception goes, just a reminder for everybody on the call. I feel like we touch on it every once in a while, but to bring it up for contraceptives, just remember that with the Mavorite, if she would want to start on birth control, the contraindication with Mavorite and anything that contains epinioestradiol, which is in most of the combined hormonal contraceptives. So you still have a lot of options with progestin only, whether it's the pill, the Micronor, like the mini pill, or using a depot, or even the drug-eluting IUDs. The only thing they have in them is progesterone. So those are all safe options for if she would want to start something for contraception. If she was on the Mavorite, you just have to watch that one interaction there.
I appreciate the reminder. Thank you.
Sure thing.
Yes, thank you so much, Rachel. All right, any other final comments before we move on to Gary's cases? All righty, well, thank you again, Jennifer, and thank you all for the feedback and comments. All right, Gary, I will pull up your cases now. It looks like we're starting with the 26-year-old female, if that's okay with you.
Yeah, that's good.
All right, I'll turn it to you now. Thank you.
So this is a 26-year-old white female. This lady, I think, has had some unfortunate luck. So she was diagnosed 2 years ago. Well, she started IV drug use about 2 years ago. She went to rehab a year ago, tested positive for hepatitis C. She was cleared with Mavorite. She relapsed about 5 months ago. She went to rehab last month, and she tested positive for hepatitis C again. So now she needs retreated. Her ultrasound showed mild fatty liver. Her elastography was F0. She does vape. She says she drinks, but it's less than 1 time a month. She's bipolar, has opioid dependence and restless leg syndrome. She's on Latuda, omeprazole, ropinirole, Suboxone, trazodone, and Vistaril. She's not immune to Hep A or B. We have since started those. Her BMI is 21.5. Her platelets 334. ALT was 64, AST was 30. APRI was 0.4, child was 5A, MELD was 7. Iron counts were okay. Her vitamin D is 34. Her serum fibrosis was F0. She's HIV negative. Her viral load is 539,000. I don't have her genotype yet. Me and Quest are going around in circles on this. They are finally running it. So hopefully I have that back soon. And yeah, Hep A and B were negative. So I know she was previously treated. This will be the first time I enter this kind of territory. What's the best choices here?
Thank you so much, Gary. I almost forgot to scroll because I was so into the case. Thank you, though. Any clarifying questions before we get into the recommendations and feedback? Everyone's welcome to unmute or chat in.
Hey, Gary, it's John. Yeah, cool case. Did with this prior treatment that the patient had, because I agree, we don't talk about many prior treatment cases, so this is unique. I'm glad you brought it up. What was it? A documented SVR12 cure on the previous Maverick course?
I don't have the records. According to the patient, she did take Maverick for 8 weeks, and she was tested a few weeks later. I mean, after she finished, and she said she was cured.
Gotcha. Okay.
So
yeah.
I don't have 100% confirmation on that.
Yeah, I have a question for you. What do you want to do with her? Do you want to get to know her a bit, or do you? Because I'm a bit nervous because
So she's actually seeing one of the other doctors in the clinic. She has established with us, and she's been pretty consistent now for basically since she got out of since she went back to rehab. She was seeing us previously. She basically said she had a lapse and it was something going on in her life at the time, but now she's back with mental health and getting back on all of her meds. So she's doing much better. And her mom was with her, and she feels like this time she has enough support that she can stay clean and that she wants to do well. So she's anxious to get treated, and just talking to her, I think she has good motivation.
Gotcha. Yeah, it's a hard one, man. I think you're right into the realm of opinion-based medicine here, which is great. This is the place to live. So we can, I think you have room to drag your feet a little bit. This would be my suggestion, would maybe be to take time to collect data on her to see if she actually, wherever they had treated her before, and maybe make her an active participant in tracking down this information to see if you can, make sure you knew what her genotype was then. And I definitely would wait and see what her genotype is now. That's number one. And try to see if she really was an SVR 12, so a genuine cure versus anything else undocumented. If we don't have an SVR 12 documented, we'd have to worry about a treatment failure. And so I think that data collection is key, and also gives you sort of plausible excuse to drag your feet while you get to know her a little bit. This is something I'm not an expert on at all. I always like it if Kaylee's seeing these patients, because she's so much better at harm reduction education, just making sure she knows where the Hep C, comes from. I see more and more people who do use clean needles, but like maybe share other stuff. So, the rest of the injection paraphernalia, they seem surprised that, but I used my own needle, but you shared a spoon or whatever. So definitely some harm reduction education strategies. And that would be my approach on this one. Technically, if you have a cure and then reinfection, you can approach it from a pure medical standpoint. You can retreat them with the same drug, same duration, blah, blah, blah. But if it's a treatment failure, it would be a whole nother ball of wax. And yeah, Kaylee, I'd like to see what you think on that one.
Yeah, thanks. I caught the tail end of it, but I had, looked over this case. But Gary, I mean, I agree with you wholeheartedly, John. I'd kind of drag my feet a little bit on a patient that's gone through DAA therapy already, and then is now coming back in for treatment again. I would suspect this is most likely going to a reinfection rather than a treatment failure, just because we see those so infrequently. I mean, if she took her medicine, reports that it cleared, the chance of a failure is about 2%. I mean, it's just, we don't see that especially with Mavorite. And even if let's say you get her old record, she was genotype 1 before and is genotype 1 again, that's not going to give you too much useful information, since we see that so commonly anyway. But I still think it's worthwhile to get those records. And like John, I think you're perfect with saying, have her play an active role in trying to get her old records. I usually, with a DAA retreatment, or I should say an additional treatment, even if it's reinfection, I typically follow them for about a year before I offer a second course of treatment, and make sure to document consistent follow-up for that time period. Because, if they're going to invest in paying for her retreatment, she has to really understand, the repercussions of reinfection again. And maybe she, like you said, had a lapse that was a little while, and, reused or shared something else with somebody else. But regardless, I'm pretty suspicious that this was a reinfection and not a treatment failure. And it's pretty hard to, and at least in our area, to get treatment approved a second time. You can, but it's just, you really have to follow them pretty closely. So I like to be a little bit more cautious with offering treatment so quickly with these patients. and definitely counseling on harm reduction, like you said, John. There's not really much I have to add from what you've already said, other than, I do suspect it was a reinfection.
And Gary, this would be an awesome represent when she helps you out with the data. If she can, like fill in the blank, if she fills in the blanks for you and then stays clean. Drug interaction wise, obviously you got the Epclusa with the PPI, I think I saw in there. And then Rachel, is Latuda, that's an antipsychotic similar to the other, like Seroquel, right? Same interactions with Mavorite possibly, but nothing you worry about.
Yeah, you nailed it. If depending on which resource you look up, it may or may not flag, but the interaction should be so mild and insignificant. I don't expect that to be a major inhibitor or make you change or select one therapy over another.
Thank you. And I can't agree more with Kaylee. We unfortunately, you're probably with the same genotype and you're not going to know. Coolest case scenario would be if it's a genotype, like a different one, then you'd be like, definitely reinfection. But yeah, I agree. Playing the odds, it's probably just a reinfection. But yeah, slow play it. You got neither Kaylee or I compared notes beforehand. We basically are saying the same thing. So
Sounds good.
I love that. Thank you all so much for the feedback, and thank you, Gary, for that awesome case. Any further comments about this case from anyone? And Gary, any questions you have about this case as well left over?
No, just gotta do some digging.
Absolutely. And if you have any follow-up later on in a few months, you're welcome to resubmit the case and we can revisit it as well. Even as just a learning tool, we don't have to necessarily present it, but show the group and see the progress. So
Yep.
and I should clarify, part of the reason we're being a tad cavalier with this is because she is just an F0 and such a recent, we got time.
Yeah.
If she was a cirrhotic, that would go out the window, but.
I understand.
All right, awesome. Thank you all so much. Gary, I will share screen and pull up your last case here. All right, I'll turn it to you again. Thank you.
So this one, she's a 45-year-old female. She was diagnosed with Hep C about 4 months ago. She has a long history of IV drug use. She started cocaine about 20 years ago, and she said she started IV drugs shortly after that. She's now been clean for about 6 months. She did go to rehab. She's doing well with all of that. Her ultrasound showed moderate fatty liver with hepatomegaly. Her elastography was F2. Her Hep A and B vaccines were started. She does drink socially. Tried to get her to quit, and she still smokes 1 pack a day. Her comorbids is she's just obese, and she does have a history of tubal ligation. She's on no medications. Her BMI is 39.2. Her platelets 224. LFTs were okay. APRI was 0.3. Child was 5A. MELD was 7. Iron was okay. Vitamin D is 36. HIV negative. Genotype is 2B. Her viral load is 4.25 million. And serum fibrosis marker was F0. I know there's some discordance between the fibrosis score and elastography. Is Mavorite a good choice for this?
Thank you again, Gary. Any clarifying questions from the group? All right, and any feedback, recommendations?
Hey, Gary, this is Kaylee. I agree. I think Mavorite would be fine with this lady. The discordant biomarkers, I only get really hyped up about those if it's like a large discrepancy. So like an F0 and an F3 or 4, or an F2 and a 3 or 4, if those kind of discrepancies, because regardless of if she's got an F2, she probably does. The elastography showed some, fatty liver and hepatomegaly. She drinks a little bit. She's got hep C. She's obese, so she probably does have some fatty liver. But it's not going to change your long-term plan. She wouldn't need any kind of HCC surveillance or anything like that. So with it being, that amount, my biggest thing is I just would follow her transaminases, which they were normal at baseline, and then counsel her on other risk factors for liver disease and fatty liver, and work on those managing those things as well. But yeah, Mavorite for 8 would be fine with her.
Thank you so much, Kaylee.
Yep. Yeah, 100% agree. Yeah, I think, and I don't know this off the top of my head, so it's a question I'm throwing out there too. I know for the elastography definitely is useful for fatty liver above and beyond just fibrosis for chronic viral hepatitis. And so I think Kaylee hit the nail on the head. That's where your discordance is here. It's probably accurate discordance. She's got fatty liver, but she doesn't have damage from her viral hepatitis. So she's got alcoholic and central abdominal obesity related fat deposition, and therefore a little bit stiffer liver, which elastography is accurately grabbing, and the FibroSure is discriminatingly not showing. So pretty cool case. I dig it. And yeah, what's crazy is it's 2 genotype 2s out of 4 patients. That's nuts. Yeah, only options Epclusa or Mavorite. So yeah, why not go for the shorter? Good stuff.
Thank you all for the feedback. Any other comments from the group about this case?
Oh, and yeah, she really got to stop drinking. You got make sure you show her that elastography and that ultrasound and be like, you're already doing damage,
I'll keep on her.
Thank you, Gary. And did you have any other questions about either case that you presented today?
No, I'm good. Thank
All
you so much.
Yes, thank you so much. We really appreciate it. And thank you all for the comments and feedback and great discussion. So those are our 4 cases for today. We have some time, so if you all wanted to discuss anything, you're welcome to. But of course, no pressure at all. I know you all are super busy. So if anything, maybe the extra time is beneficial. So just let me know. I'll go with the flow. All righty. Well,
I have a question, Mitra.
Yeah, of course, go for
All
it.
right. This is like, yeah, I should know that hearing so many cases and stuff. So when you guys, like, if somebody has non-alcoholic fatty liver, or do they have to completely stop drinking, or can they still drink on occasion, like on a weekend? Is one drink that detrimental?
I need Dr. Feinberg to answer that. I don't know the answer. Kaylee, do you know?
Well, so if you think about it, I mean, you might be labeled, I guess the only difference between alcoholic fatty liver and non-alcoholic fatty liver is either alcohol's the thing causing it or it's not. And so the label, the really only way to differentiate the two is either alcohol's in the equation or it's not. So even if you're still having an alcoholic drink every so often, there's that alcohol is still kind of flaming up the underlying. So if there's no fibrosis, I guess it really just depends. I'd probably still recommend against all alcohol, just because that's still going to be contributing to it regardless. But I mean, I guess we're human, and so if every once in a while, like once a year, if it's a special occasion or something like that, I think maybe you could get by with 1 or 2, and it's not gonna kill you unless you already have cirrhosis related alcoholic fatty liver. But yeah, I would overall still recommend against it. And the good thing is that fatty liver is completely reversible. So if you get the underlying causes managed, it can go away. So just because, it's very dynamic, if it's something that you're avoiding now, then, a couple years from now, if whatever was causing the fatty liver to begin with is well controlled and that issue is resolved, then, sure, I don't want to strongly say, hey, it's cool to go and drink. I can't formally recommend that, but offhand, yeah, I don't totally say, hey, you never can have one ever again, unless there's already, pretty substantial fibrosis as well.
Thanks. That was just a curiosity type of question.
Yeah, totally. And I didn't really answer it, but
No, it's fine. It's complex. I'm sure it's like case to case related and individual.
yeah, I mean, it's just more so it's treating the underlying. So if you're really still have other risk factors, really the main thing is to make sure that you're removing all of those risks. So I guess you can't formally say, hey, yeah, alcohol is okay, but is it really going to be the thing that tips you over the edge if it's